The following podcast is part of a certified educational activity featuring Suresh S. Ramalingam, MD, FACP, FASCO from Emory University School of Medicine, Alexander Drillin, MD from Memorial Sloan Kettering Cancer Center, and John Haymack, MD, PhD from the University of Texas MD Anderson Cancer Center. Access the entire activity and complete the post-test at peerview.com/VVS860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello, welcome to this program, Everything You Need to Know About Molecular Testing and Targeted Therapies in Non-Small Cell Lung Cancer. Essential guidance for modern, patient-centered precision lung cancer care. My name is Suresh Ramalingam. I'm a thoracic oncologist at Winship Cancer Institute of Emory University in Atlanta. I'm pleased that we're joined by two prominent leaders in thoracic oncology for this conversation. Dr. Alex Drillin from the Memorial Sloan Kettering Cancer Center in New York and Dr. John Haymack from the University of Texas MD Anderson Cancer Center in Houston. John and Alex, welcome to this program.
Thank you.
We'll start this conversation talking about where we are with precision approaches to treating non-small cell lung cancer. We will focus on the evidence that drives the care of patients with non-small cell lung cancer in our clinic. Then we will talk about practical considerations when it comes to applying this evidence to manage our patients. And finally, we will close down with some take-home points for you to manage your patients. So let me start the conversation by telling you how far we have come in the treatment of non-small cell lung cancer in the past several years. From an era where we treated all patients with non-small cell lung cancer alike, we're now beginning to treat patients based on their specific genomic characteristics or immune characteristics. We no longer view lung adenocarcinoma as one disease. Lung adenocarcinoma, as you're well aware of, accounts for approximately 50 to 60% of all non-small cell lung cancers that are diagnosed in the United States. We now, by using genomic approaches, are able to break them down into specific subsets based on the driver mutation or fusion event that's driving that patient's particular situation. In lung adenocarcinoma, there are at least 7 different molecular targets which have FDA-approved targeted therapy approaches. And we're going to cover every one of these driver events and talk about the various treatment options that are currently utilized for the management of these patients. Now, there are also other promising targets with promising therapies that are knocking on the doors and will hopefully be available to us to use in the clinical practice setting in the not too distant future. We're also seeing something very exciting, which is moving these targeted therapies for the treatment of metastatic disease as it exists in the current setting to earlier stages of non-small cell lung cancer. We'll particularly talk about the ADORA trial, which has looked at EGFR inhibition in patients with early stage non-small cell lung cancer. Now, as we apply these exciting advances in our clinic, it is also increasingly clear that working closely with our patients and caregiver community is critical to achieve the best outcomes. As more options become available for each indication, having a candid conversation about the pros and cons of each of these therapeutic approaches, so we can make the best decision in a shared decision-making model that works for the given patient sitting in front of us in the clinic. So from that point of view, we're excited that the GO2 Foundation for Lung Cancer is partnering with us in this education program. The GO2 Foundation is one of the leading patient education, advocacy, and research organizations that's exclusively focused on lung cancer. So let's start the conversation about specific targeted therapies and other modalities that are used to treat patients with lung cancer. And I'm going to bring in Dr. John Haymack as we talk about the various targets. John, in your practice, when you have a patient with advanced stage non-small cell lung cancer, tell us about how you approach molecular testing.
Yeah. Well, thanks, Ram. It's an exciting time because not only do we have all these new options, but the therapies are often really effective. Some of these new targeted therapies can really give spectacular outcomes with minimum toxicity for patients. So one thing I tell our trainees is the biggest mistake you can make as a thoracic medical oncologist is to not find one of these driver mutations. A lot of the other therapies we think about, which immunotherapy you choose or which chemotherapy. All these really are minor decisions compared to that one issue. Do you find a driver if it really exists? So our approach for these drivers, first of all, we try to do it initially from tissue from all our patients. At MD Anderson, we have something called the Oncomine panel that we use, but there's a number of other ones that also do a very good job. We have patients coming in with garden profiling or from Foundation One or from other sources. I think all of them can absolutely do the job. If the initial biopsy doesn't give the information that's needed, we'll next send off liquid biopsy. And it's not perfect, but it does capture it. In our hands, it captures it in about 85% of the cases, meaning that if a driver is really there, like EGFR, you'll find it about 85% of the time if you send a liquid biopsy. Now, if we still have a strong suspicion and both the tumor and the liquid are negative, then we'll often go back and rebiopsy. But the thing we never want to do is miss a potential driver, because that's the single piece of information that can have the biggest impact on what your patient gets.
Great point, John. Alex, one of the questions that physicians often are facing in their clinic is they have a patient who is clinically not doing very well. The symptoms are rapidly getting worse. And the question is, I don't have the results in my hand yet from the molecular test. I do feel the need to start something. What would you tell them?
Yeah, so it's a situation that we face very commonly, and obviously the patient and how he or she is doing needs to be at the center of our decision making. I think if someone's really floundering and needs therapy, then the onus is on us to start what's available. And we know that across many of these drivers, chemotherapy with a platinum doublet is an active therapeutic. And I think the one thing that I would caution is the potential use of an immune checkpoint inhibitor in the face of someone where you might very strongly suspect that a driver is present. Say the typical younger never smoker phenotype, because we have emerging data showing that some of the tyrosine kinase inhibitor therapies that we administer, both the ones that are approved already by the FDA or ones in development, might be affected in terms of the likelihood of toxicity after an immune checkpoint inhibitor. So my bias in a patient like that is to start with platinum doublet therapy and not with an immune checkpoint inhibitor by itself or chemo IO.
That's very important guidance for our colleagues, because once you start immunotherapy, these drugs have long half-life, and it's not easy to stop it and switch to something else entirely without having the potential drug-drug interaction. So let's dive into the first target, EGFR inhibition in non-small cell lung cancer. John, it's been a very exciting 15 years in the EGFR landscape. We have 3 generations of EGFR tyrosine kinase inhibitors. Now, FLORA study showed osimertinib as being superior to gefitinib or erlotinib in the frontline setting. It has PFS benefit, overall survival benefit. Talk to us about how you use all of these data to make decisions for a patient with exon 19 or 21 mutation in your clinic.
Yeah, well, treating patients with EGFR mutation, and when I started treating patients, we didn't have EGFR mutations as a diagnostic test. It was just chemotherapy. So starting with the introduction of EGFR mutation testing and using these drugs for those patients, it's really been a steady improvement over time. And really, it's gratifying now to see that the expected median survival for somebody who's showing up as a newly diagnosed patient with a sensitizing EGFR mutation is now in excess of 4 years, and I think it's getting even better than that. So the way I consider it, again, to remind people, the two standard sensitizing mutations are L858R and exon 19 deletion. And if you've got one of those, historically we had the first generation drugs, gefitinib or erlotinib. That gave way to second generation drugs like afatinib and dacomitinib, more active, but with significant toxicity still. And now third generation drug, osimertinib. Now, osimertinib, of course, was originally improved for the resistance mutation, the T790M. But now we've had a very exciting frontline study called FLORA. And so FLORA compared the osimertinib against two other frontline first-generation drugs, gefitinib or erlotinib. And it was really clearly superior. So the median PFS for osimertinib is coming up on about 19 months, as compared to 10 to 12 months is what we're used to with the first and second generation drugs. Another important advantage of osimertinib is significant CNS activity as well. And that's a really, I think, important plus, because a lot of patients present with CNS metastases or develop it subsequently. Erlotinib and gefitinib have a little bit of CNS penetration, but it isn't great. So this is really a clear advance for patients. Now, it does create a bit of a conundrum for treating physicians in that previously when we had first and second generation drugs, they would commonly develop T790M as a resistance mechanism, and then you could use osimertinib for T790M. Now when we start with osimertinib, we no longer get T790M mediated resistance. We get a lot of different types of resistance. But there isn't a single treatment we can use for all those resistant patients. So now we've got to develop better approaches for osimertinib resistance. But this has really been a clear advance for patients, and patients really tolerate these drugs very well overall. Again, high CNS activity, so this has been a clear win for patients.
Thank you, John. What our audience can see is the Archer 1050 trial. John, you alluded to the second generation data. This trial showed that dacomitinib, a second generation EGFR TKI, was superior to gefitinib in this trial. You can see a substantial improvement in PFS. So this is an FDA-approved option, and we're still trying to figure out where this particularly fits in with increasing adoption of osimertinib in the frontline setting. Alex, the combination of erlotinib and ramucirumab is now FDA-approved for EGFR-mutated patients. What can you tell us about your interpretations of the Relay trial and how this might help us in the clinic?
So first, I'd like to say that this is obviously a very interesting result. So conceptually, we're seeing that the addition of anti-VEGFR therapy does result in meaningful benefit, so longer progression-free survival, as you see on the slide. But that's in addition to a first-generation EGFR TKI erlotinib. Now, we're currently exploring the addition of VEGFR-directed therapy to third-generation contemporary EGFR TKI therapy, and the results remain to be seen. But I think the bigger question here would be sort of patient ease. And if you're going to lean on something like the Relay regimen, then it means that a patient's coming in more frequently for intravenous infusions versus if they're taking a single agent TKI, then it's something that they take at home. Obviously, they can be seen every 3 months if they're cruising and doing very well on therapy. So I think what we need to look towards will be the readout of third generation TKI plus anti-angiogenic therapy to see if there's a much more meaningful increase in clinical benefit. And if we do see that, then that might change our mind, and we might say it might be worth it for someone to come in rather than come in for the infusions rather than just come in every few months.
Absolutely. And we could also say that the similar approach of chemo plus TKI in the mutated patients is showing some potential benefits, and that's also being studied in randomized trials. So that might be something to keep our eyes out for.
Yeah, and now, Ram, I guess I can, if I just add to this, I think does present an interesting choice for patients and physicians having this option available. And I'm glad that it is available. There have been a number of studies that show EGFR mutant patients are more sensitive to VEGF inhibitors. And, I've spoken with different groups that view this differently. On one hand, you can start with the relay regimen. And again, the median PFS was about the same as osimertinib, about 19.4 months for relay with erlotinib plus ramucirumab versus 18.9 for osimertinib. But you do have the inconvenience of coming to the physician for intravenous infusions. You've got a little worse tolerability for erlotinib, but you do have the potential to use osimertinib later because T790M is still the most common resistance mechanism that emerges for relay. So the disadvantage of using relay is that it means coming for more infusions and you're getting a drug that isn't as well tolerated as osimertinib to start with, or a regimen. But the advantage is you may be able to use osimertinib later if T790M emerges, and that may delay the overall time until chemotherapy. So I think it presents an interesting option. It's not for everybody. The study didn't include CNS metastases, for example. But there were some subgroups that I think really got a lot of benefit from this regimen. If you look specifically at the L858R subgroup, they didn't do as well with osimertinib. They did well with the relay regimen. So it's good that that there's increasing choices in the space, and I think there are some patients that this is worth having a discussion with the provider for. But I agree with Alex that the third generation plus VEGF inhibitors really is something that'll be exciting to see, when we do get the readouts from those studies.
Absolutely. And I think the one thing we're all excited about is moving this into early stage disease. Alex, the ADAURA trial has now been published. It showed substantial benefits with osimertinib in the postoperative space. Can you briefly talk to us about the ADAURA trial and your take-home messages?
Sure. So essentially here we're looking at patients with non-metastatic earlier stage disease that you see on the slide. And we're looking specifically at the Kaplan-Meier curves of disease-free survival when patients with stage 1 to 3A, 1B to 3A disease to be specific, were randomized to osimertinib versus placebo. And it's very obvious on this slide that there was a difference in patients in the blue curve who got osimertinib compared to placebo. Now, I think, the results have really split the community a little bit. While we're also seeing additional factors like improvement in CNS disease-free survival, when you ask someone about whether or not they would use a strategy such as this, you either get the camp that really wants to see a substantial overall survival benefit, or those who recognize the utility of leaning on adjuvant therapy, TKI therapy. And I think I fall into the latter bucket because certainly I've seen patients who have recurred where the recurrence can be very widespread and sometimes catastrophic. So you often wonder what would have happened if the TKI was in play prior to that. And so I think my personal preference here would be if I have a patient, especially with later stage disease, that has the option to do an EGFR TKI, I would give it in an adjuvant fashion.
Thank you, Alex. Before we switch off the EGFR topic, we do have a couple of, or exon 19 and 21 topic. We have a couple of questions from our audience. The first question, John, is you alluded to some of this earlier with multiple options for first-line therapy. What factors do you consider in your clinic? We talked about brain mets. Anything else that you want to share with the audience today?
Yeah, well, I think right now the best single agent that we have is clearly osimertinib. So if you've got a sensitizing mutation, I think osimertinib is clearly one answer. The other regimen that has comparable PFS, at least as I mentioned, is the relay regimen, or erlotinib with ramucirumab. So that is a discussion I do have with patients. I think patients that may be particularly well suited to that are ones who want to be aggressive in their treatment and are willing to have the inconvenience of frequent visits in exchange for having osimertinib potentially to use later and delaying the time to chemotherapy. So I think that's that's a discussion one can have in patients who don't have brain metastases, and potentially those with L858R mutations that seem to do better with the relay regimen than with the osimertinib, although they weren't compared head to head. Let me just mention one other group that's important. A group that we used to really ignore for the most part were those that didn't have sensitizing mutation, but this is about a quarter of EGFR mutant patients that have these so-called atypical mutations. Now, atypical mutations come in a couple of different flavors, and one set of drugs we'll talk about later are the exon 20 drugs, and there's a number that are emerging there. We have other atypicals that I think are worth keeping in mind. We have some exon 18 mutations. So exon 18 mutations include 709, 718, 719. And then there's the S768I mutation and L861Q. For those, afatinib is actually an FDA-approved drug. So we want to make sure people are aware that there is at least one drug that's approved for the non-sensitizing mutations right now. And we do have some exciting trial results emerging for some of the other drugs as well that are in testing right now.
John, I want to follow up on what you just mentioned about these atypical mutations. Exon 20 insertion mutations are seen in about 7 to 8% of all EGFR mutated patients. These patients traditionally do not respond to our TKI therapies that are used for the exon 19 and 21. You and your group have been at the forefront of developing novel options. Knowing that there is no FDA-approved option for this, what do you see on the horizon that's promising for this group of patients?
Yeah, well, there's been, I think, several clinical studies that have shown promising results so far. We'd identified poziotinib, which is a drug that had been discontinued earlier, as being active in both EGFR and HER2 exon 20 mutant patients. Now, we did a phase 2 that showed promising early results. Now there's been a larger registration study, and the registration study is a split decision. So it achieved its primary endpoint for the HER2 insertion patients, but it missed its primary endpoint for the EGFR exon 20. So that's one that clearly is active, but didn't quite hit the bar for EGFR, but did achieve the bar for HER2. Now, we've got a couple of other drugs that I think look really intriguing in this space. So one is TAK-788. This is a drug that's been granted breakthrough drug designation. So this is now in more advanced studies for EGFR exon 20 insertions as well. And then there's a bispecific antibody that targets both EGFR and MET that I think also has very interesting activity, not just in EGFR exon 20, but other atypical populations. And that has also been granted breakthrough drug designation. So neither one is approved yet, but I think both have a potential in the space. So I believe for EGFR exon 20, we are likely to have a drug that gets approved in the foreseeable future. And I can tell you that there's a number of other drugs that are in the pipeline that are coming right behind them. It's a more challenging set of mutations to inhibit specifically without having the toxicity associated with EGFR. But we've learned a lot in the last few years. So these drugs are getting better and better. And if it's not with this set of drugs, then the generation right behind it, we will have drugs, I think, in the near future to use for these patients.
That's very encouraging, John. Much needed for this particular group of patients. Alex, as we talk about targeting EGFR, Dr. Helena Yu from your institution recently at ESMO 2020 reported some very intriguing data on an antibody drug conjugate that targets HER3. Can you talk about that?
Yeah, and I think this really highlights how, very interestingly, we're returning to the antibody-directed targeted therapy field, but really capitalizing on these more novel strategies of linking a warhead or a very active chemotherapeutic agent to a naked antibody. And that's what we're seeing here with patritumab deruxtecan. And the antibody is directed against HER3, which is an ERBB family member that we've long known to be involved with oncogenic signaling, including in the resistance space to prior TKI therapy in EGFR mutant lung cancers. And as you can see here, you're seeing a waterfall of patients with EGFR mutant non-small cell lung cancers, many of whom responded to the ADC therapy. But what's notable is the real heterogeneity of the variety of genomic events that you see below, where you have not just patients with sensitizing mutations who had been exposed to prior TKI therapy, you're also seeing there patients who have T790M mutations, and beyond that, even amplification of other receptor tyrosine kinases or potential bypass pathways that may mediate resistance to our conventional therapies. So I think that these results are highly exciting. Obviously, we've seen TKI class saturation with the number of therapeutics that have been approved for oncogene-driven cancers in the lung cancer world. And it's nice to see that, there may be hope on the horizon with these antibody drug conjugates.
Great. Now, sticking with the topic of ADCs, John, we have seen some very exciting data with HER2-mutated patients in another ADC. You already spoke about poziotinib in HER2-mutated patients. Talk to us about the Destiny trial.
Yeah, so this is an antibody drug conjugate called DS-8201A. It's trastuzumab conjugated to the same warhead that you just heard about, deruxtecan. And this has really been, I think, a very exciting result. So for HER2 mutant non-small cell lung cancer, a really impressive activity seen, confirmed objective response rates in the first 26 patients of 61.9%. Now this looks, even though the numbers are small, this looks better than what we saw with trastuzumab or TDM1 previously. It looks higher than what we've seen with poziotinib in terms of the progression-free survival and the overall response rates. So this has really been encouraging activity. And while we don't have all the mature PFS data and the final response rate data, it does look like a number of patients have had very long progression-free survival here. So I'm enthusiastic about this agent and hoping that we have at least one drug, if not multiple drugs, available in this space shortly.
Yes, definitely intriguing data, and hopefully HER2 will become the 8th or the 9th target with FDA-approved options as we move on into 2021. An area where we've had plethora of success is the ALK inhibition. Alex, this landscape has changed so dramatically in the past few years. We have incredibly effective frontline agents. The median survival for this group of patients is now well above 5 years. Walk us through the developments in the ALK TKI space. What's your preferred frontline approaches?
Yeah, and Ram, I think this is a commentary on the fruits of rational drug development. So as you can see on this slide, we started out with first generation crizotinib, but then later on developed second generation agents that were characterized by not only improved CNS penetration, but also resistance anticipation. And then that last piece was kind of dialed up a notch further if you then look at the third generation drug lorlatinib that inhibits a wider swath of different on-target acquired kinase domain mutations that you might see with early generation TKI therapy. And if we move to the next slide, now we know that using the strategy of a next generation tyrosine kinase inhibitor up front, echoing what we talked about for the EGFR space where osimertinib has displaced earlier generation EGFR TKI therapy, here we see the ALEX trial where we're comparing alectinib to crizotinib, second versus first generation. You're seeing improvements in progression-free survival, and also on the right, notably substantial outcomes in the central nervous system, both in terms of regression of target lesions in the brain and prevention of CNS events, as you can see in the curve on the lower right. And this is now a current standard of care after it's replaced crizotinib, the former standard of care. And we're also seeing brigatinib in the ALTA-1L trial achieving similar results. Again, I would say that brigatinib shares many features with alectinib, resistance anticipation, CNS coverage, so we're not surprised to see it in this randomized trial again beat crizotinib. And this is also currently available for use in the TKI naive setting. But perhaps this year, in the next slide, we've seen the results of the CROWN study, which have asked the question, if we put a third generation ALK tyrosine kinase inhibitor upfront in the treatment naive setting, what happened? So unsurprisingly, we're seeing a divergence in the progression-free survival curves that you see there on the left. And interestingly, and this is the caveat here, is that I'm talking about cross-trial comparisons. You have the lowest hazard ratio in the randomized trial of a next-gen TKI versus crizotinib. Now, the bigger question here will be, obviously, when osimertinib was moved up front, we not only had a better drug, but it was also more tolerable, as John points out. Well, here, lorlatinib does come with a baggage of additional side effects, such as hypercholesterolemia, cognitive changes, neurologic adverse events. And I think the success of a drug moved up front is really predicated on patients tolerating the drug if they stay on for a long time. So it remains to be seen what is the winner in upfront therapy. But right now, I think because of inertia, my preference is to give alectinib upfront or brigatinib if there's an issue with alectinib tolerability.
Thank you, Alex. John,
So, Ramya, if I could ask Alex, and it's reminiscent of the discussion we had before with the Relay study and the Flora study in the EGFR space. So you've got a regimen that I think most of us would say is a little less well tolerated than alectinib or brigatinib. But as you pointed out, that's a really impressive hazard ratio. A hazard ratio less than 0.3. We don't even have a good median PFS yet, but clearly impressive activity. But we also have that drug being approved in the second-line setting, and we have that experience there. So similar to what we said before, you could have sort of a less well-tolerated upfront regimen, or you could hold it for the second-line setting and use alectinib or brigatinib first. So how do you discuss that with your patients?
Yeah, I think, we always present the options of potentially doing both. I think that from a patient-centered view, it's always appealing to have another pill in your back pocket to give after a first pill. And so most patients would obviously take the option of doing sequential TKI therapy. And we have seen good results with lorlatinib after one or more prior TKI. So I think right now that's a strategy that I lean on.
And in fact, you answered one of the audience questions, which is with all the available options, how do you choose? One other drug that has also shown benefit in this space is ensartinib, another next generation ALK inhibitor that showed superiority over crizotinib. So a lot of great options for ALK-positive patients. Let's talk about ROS1. This is a target that's seen in about 1% of lung cancer patients. We have 2 approved drugs for this space. John, can you walk us through the evidence supporting targeted therapies in this setting?
Yeah, well, like the other fusions, these are clear oncogenic drivers if you've got ROS1. And it's one that's highly responsive, and there are great drugs that have emerged, and they're getting better and better. Crizotinib was the first drug in the space, and this was originally developed as a MET inhibitor, and then, of course, found at home as an ALK inhibitor. And then, had activity in ROS1. So this was the Profile 001 study. And, I think that the take-homes from this, first of all, it's clearly active. It's got a very good median PFS, 19 months. So this is clearly an impressive drug. It does have some minor issues with tolerability, and there are some questions whether the fusion partner makes a difference here. But overall, it's certainly a reasonable option, and it's been my go-to option until recently. Now, more recently, we've seen the data with entrectinib, and this is a drug we're familiar with also from the setting of NTRK fusions. And this is really a wonderful drug. Really impressive response rates of 77%. Median PFS are around the same, but again, the overall sense is that there's a higher response rate and very clear activity in the CNS. And this might be the most important feature, to my mind, that distinguishes it, because crizotinib does not have great CNS activity. We know that's the vulnerability of the drug, and entrectinib does have very good CNS activity. So, I think we've got at least two very good options now for these ROS1 fusions, and I think other drugs coming along that also have promising data as well. So I'm excited about entrectinib, and I've just started writing this for patients recently.
Let's switch gears, talk about BRAF mutations. Now, we see BRAF mutations in 2 to 3% of patients with lung adenocarcinoma. Now, I would like to point out that not all BRAF mutations are targetable at this point. We specifically talk about V600E mutations as being targetable. These are about 50% of all BRAF mutations. For this group of patients, we have dabrafenib and trametinib approved by the FDA as a combination. The response rate is about 65%. The median PFS is about 10 months. So this combination is quite active in this patient population and is used in the frontline setting for BRAF V600E mutated patients. If you give BRAF inhibitor dabrafenib alone, the response rate is only half of that. So it's important that we use the combination approach for V600E mutations, making this yet another bona fide target with treatable situation. Another target that we have seen with effective therapy is TRK inhibition. Alex, entrectinib and larotrectinib are both active. Talk to us about the data here.
Sure, and this is an interesting driver because this targeted therapy approval for both larotrectinib and entrectinib represented the first approval of a targeted therapy for a molecularly enriched indication. And so here we're talking about TRK inhibitors for TRK fusion positive cancers of any histology, so tumor agnostic approval. And in these waterfall plots, you see the drug is very active, not just in TRK fusion positive lung cancers, but also in a variety of different histologies from adult and pediatric cancers that harbor these fusions. You have high response rates approaching 60 to north of 80%, and very durable disease control with long progression-free survivals and durations of response. And both of these drugs, as pointed out, are already FDA approved. I think that we're going to continue to rely on histology agnostic drug development as we realize that these molecular signatures are present across different cancers. Just to call out the frequency of this in lung cancer, it's much less than 1%. But I think capitalizing on the fact that we can aggregate many different cancers with the same signature into a trial that includes not only adult but pediatric patients has represented a substantial advance in this field.
Excellent. We are now moving to RET inhibition. And Alex, I'm going to ask you to chime in here again, given the amount of work you've done with bringing in RET inhibitors into the clinic. Selpercatinib and pralsetinib are both now available for frontline therapy. The data look very interesting. What are your recommendations for our audience with managing RET fused non-small cell lung cancer?
Yeah, absolutely. So RET fusions occur in up to 1 to 2% of non-small cell lung cancers. As a very brief sidebar, prior to 2017, we had so-so drugs, the multi-kinase inhibitors with some modicum of inhibition against RET. Some of them, like cabozantinib, made it into the NCCN guidelines, but we knew that response rates were modest and activity was high because these inhibited a lot of targets apart from RET. But in mid-2017, we saw the introduction of these rationally designed selective RET inhibitors, such as selpercatinib and pralsetinib. And we've seen the advancements that these drugs have brought to the field in terms of both activity and safety. So here we see the waterfall plot of selpercatinib in previously pretreated patients, patients who have had an immune checkpoint inhibitor previously, a multi-kinase inhibitor, platinum doublet therapy. And unsurprisingly, below we see that the drug also works well in TKI naive, actually previously untreated, treatment-naive patients. Finally, it's also encouraging to see that this drug can work very well in the CNS, and you see CNS target regression on the right. And we actually published a case of a patient with complete clearing of her RET fusion-positive leptomeningeal disease, reminding us of what osimertinib, for example, can do in that space. And going on to this next slide, the other drug that's also selective is called pralsetinib, formerly Blue 667. Similar results here, high response rates, very nice waterfall plot, deep responses to therapy, and a drug that's already approved. So I think that we have two really good options for these patients that were just approved with no prior approvals for this space. So it's a big win.
Absolutely. It is a big win for our patients. We have some questions, John. I'm going to ask you to comment on this from our audience. Based on the data that we just saw for pralsetinib and selpercatinib, do you view these as frontline drugs? And what is the role of immunotherapy in patients with RET-fused non-small cell lung cancer?
Yeah, those are important questions. So the first answer is yes. I mean, if you look at the outcomes for these drugs, the median PFS, the response rate's about 65%. That really is dramatically better than chemotherapy. And these drugs, both selpercatinib and pralsetinib are both well-tolerated drugs as well. So for me, it's really no comparison if you've got that diagnosis of RET fusion non-small cell up front, and you have a choice between a TKI with these long median PFS and high response rates in excess of 60% versus chemotherapy. I would absolutely go with the TKI in that setting. And I think whenever possible, you want to go with your better drug first. Now, the issue of immunotherapy is, I think, an interesting one. Marcelo Negrão in our group has reported a cohort of RET fusion non-small cell lung cancer and their outcomes on immunotherapy. And the outcomes are not very good, like other driver mutations. They're not highly responsive, at least to PD-1 monotherapy itself. So this raises the question, should they get immunotherapy at all? Should they get it as monotherapy? My feeling is I do keep it as an option, but I put it later in the game. I think patients are often anxious to get immunotherapy. It's intellectually a very appealing thing to get to stimulate your immune system to attack the tumor. But I think I would go with multiple other things before that time. And there's always at least a theoretical concern that if you give the immunotherapy too soon, subsequent TKIs may face toxicities like pneumonitis as well. This hasn't been as much of an issue with the RET inhibitors overall. So again, my perspective here is I will use immunotherapy, but I really keep it as a late option for these patients and really focus on getting those TKIs first and platinum doublet agents second.
I think that's important for our audience to know because, as you rightly point out, John, patients want to get immunotherapy based on everything that's been seen and heard. Now let's switch gears, talk about another mutation, MET exon 14 skipping mutation. John, there are, again, multiple options here. Capmatinib, tepotinib. This mutation is seen in about 3% of non-small cell lung cancer patients. What are your thoughts on the capmatinib data and then the tepotinib reports recently?
Yeah, well, like we discussed for RET, we've got now another pair of really good drugs that are highly effective, well-tolerated drugs. We have more experience or involved in the tepotinib study, but my experience with capmatinib has been similar. Let me first mention a couple of points that I think are salient for MET exon 14 splice mutants that make it a little bit different than the other driver oncogenes. We have a type patient in mind, sort of an archetype of somebody with an EGFR or an ALK mutation, sort of often a younger patient, non-smoker, typically a well-differentiated adenocarcinoma. MET exon 14 mutants, it's often a different population. So first of all, they're often older patients. So just to remind everybody, don't forget to screen your older patients for driver mutations. And they're not always well-differentiated adenocarcinomas. In fact, they're often what are called by pathologists sarcomatoid differentiation, or even squamous tumors. We recently did a big analysis of over 500 patients with squamous histology to look for drivers. And one of the most common targetable mutations in squamous cancers is MET exon 14. So just a reminder that even though it's less common, squamous tumors can have driver mutations. So absolutely consider screening them as well. But getting to the data here, I mean, I think that you can see the data with capmatinib, and now capmatinib is FDA approved. And tepotinib, that we look at here, both of them have high response rates, in that neighborhood of 50 to 60%. Both of them have high response rates in the first line or the chemo-naive setting, as well as in the refractory setting. They're both well-tolerated drugs, and I think it's exciting for patients to have two good options, assuming tepotinib gets FDA approved down the road. Right now, to be clear, capmatinib is the only one that has FDA approval for either the first or second line setting. And I'll just say, we have used crizotinib for some of these patients in the past, but to my mind, capmatinib is clearly a superior drug.
Thank you. Now, we've talked about many actionable targets leading up to this. One target that is quite common in non-small cell lung cancer, but has not had successful targeted therapy approaches, is beginning to show some promise. So, Alex, what are your observations about targeting KRAS, specifically the G12C mutation, which is seen in about 12-13% of all lung adenocarcinomas?
Yeah, I think this is a space where we've waited a very long time for a potentially active agent. And, despite the wildly unsuccessful list of prior therapies that were directed towards KRAS in general, now we've learned to design drugs that really are selective for the KRAS G12C mutant protein. And those are drugs such as sotorasib or adagrasib, for which we've seen a clinical readout of their activity. So here you see a waterfall plot where many patients will have disease regression with therapy. And in the next slide, you'll see the other drug, the MRTX849 compound, also with a similar waterfall plot. However, we're not seeing response rates yet that are in the 60 to 80% ballpark that we like to see for other drivers in non-small cell lung cancer. Also, if you look at the durability, it doesn't seem like we're seeing patients consistently stay on these agents for a long time. Now, it's not because they're toxic, actually quite the opposite, because G12C doesn't exist in non-neoplastic tissues in the body. But I think what we're seeing here is that biologically, these tumors may be reliant on other things apart from KRAS G12C and might require a second agent in order to abrogate that sort of primary resistance, if you will. And so now we're seeing the introduction of these combination clinical trials where you have a G12C plus X inhibitor. And I hope that we'll see even better results. But the ones that you're seeing here already are unprecedented, given that we haven't seen results like this in the KRAS world for a very long time.
Absolutely. John, I would be curious to hear your thoughts on where this field is heading. What do these data mean for our patients?
Yeah, well, this is really, I think, going to be the most exciting area for progress, over the upcoming 5 years. KRAS, we all know, has been the most frequent oncogenic driver in non-small cell. It's about twice as common as EGFR mutants in the North American population, different in Asia, where EGFR mutants are a bit more common. And out of KRAS, we have a number of common alleles: G12C, G12V, G12D, G13 mutations. But G12C is really the bulk of them in lung cancer. It's a little more than half of them overall. So this population, the KRAS G12C population, is about as big as all EGFR mutants in the North American or the Western population overall. So this is really a big deal that we have drugs that are active here. Now, as Alex mentioned, the response rates so far absolutely look promising, but we're not seeing things like with ROS1 or ALK with a 70% response rate and greater than 18-month PFS. The PFS looks shorter here. The response rates are a bit lower. I suspect this is because KRAS is a more heterogeneous tumor type than, for example, ALK. We think there's a lot more ways that it can adapt and become resistant when it has KRAS signaling. So this may be not a function of the drug so much as just the biology of the tumor. And I agree with Alex. What we're going to be spending our time doing the next few years is figuring out the right combinations and how to tailor them. One of the possibilities we think is hopefully going to be fruitful is looking at the additional mutations along with KRAS and whether they can help guide what drugs you add together with these KRAS inhibitors. But I have no doubt that KRAS G12C inhibitors are going to find a place in the clinic, and hopefully sooner rather than later.
Definitely. Clearly, an important reason for us to be optimistic about management of these patients in the very near future. This has been a whirlwind tour of a number of targets with exciting therapies. In the last part of this session, we want to talk about some of the strategies our panel recommends for genomic testing in non-small cell lung cancer. There's a lot of conversation about who should be tested. Should it be an older patient? Should we use smoking status? Should we use age? We've touched upon this, but Alex, do you want to briefly talk about which patient should be tested for molecular targets?
Yeah, and I'll call out again that subset that John mentioned, the MET exon 14 positive lung cancers, where you don't see the typical younger, never smoker female archetype that we used to think of. And so my answer to the question is, I think that our approach should be, if there aren't issues with payer coverage, not to be biased with the type of cancers that we send for comprehensive sequencing. So not only test younger patients, consider testing beyond adenocarcinomas, and also not just limit your testing to patients who have never smoked before. And in fact, I would even argue that now that we have many of these clinical trials that are looking at neoadjuvant or adjuvant molecularly directed therapy for these patients, that there is a role for potentially defining the genomic status of your patient's cancer in the earlier stage setting. I think at the very least, having that information in your pocket for when a patient has a recurrent disease allows you to come in with the most highly active therapy that's matched for that particular signature.
Yes, absolutely. And that also leads off to another question when we talk about various targets. John, is it fair to say that the debate over just testing for one target at a time versus just doing NGS and getting all the information upfront is settled, or do you think there's still some case to be made for single gene or specific targeted testing?
I absolutely hope it's settled. And this is a really important issue because I think when we just had EGFR, you can say, well, you don't really need to know all these others. It may be of research interest, but not for routine clinical practice. And then with EGFR and ALK, it became a little more complicated. Now that you've got 7 that have FDA approval, 7 different alterations, and the fact that I think it's not feasible to do sequential testing. I think that's to the detriment of patients. And in our hands, tests like FISH that had been used before for fusions can miss a lot of patients, and you exhaust your tissue very quickly because each one of them requires a separate section or two, at least. So I really hope now, and the recommendations from the major relevant bodies, including ASCO and CIMP and the ISLC, is to do next generation sequencing that covers not only these 7, but others more broadly. And I think that's one of the benefits of NGS is you not only get the 7 alterations that we've discussed, but you also find KRAS. And so you can refer patients to KRAS trials that we've got now. You find HER2 mutations. Again, promising data for those. You can refer those patients to clinical trials. And we have a number of other more rare alterations that I think we have effective drugs coming soon for as well. So I strongly advocate for next generation sequencing. And just to emphasize a point that Alex made before, I think it's really important not to limit your testing to some specific type of patient. I've heard physicians say, well, this patient's a smoker, so they probably don't have a driver. Well, smoking doesn't prevent you from getting a driver mutation. So I think it's important to test drivers, test older patients, test both males and females, because anybody can have a driver mutation. Some of them, like MET, occur in different histologies. So test widely and make sure you get a clean answer. It's very common. You do a biopsy, it's insufficient tissue, and by this point you've moved on to treatment, and you can forget about the fact that you don't have that answer. So, I think the most important advice I'd give to medical oncologists, make sure you get a clear answer to the question, does this patient have a targetable driver?
John, there's also, on top of what you said, there's now increasing evidence that just doing DNA sequencing alone might actually miss some molecular aberrations. If you have a DNA sequencing panel that's negative, there's some suggestion that in 1 out of 7 patients, using RNA-seq can pick up some gene rearrangements or fusion. So you also want our audience to be aware of that possibility. Any comments on that?
Yeah, no, I agree with that. I think this has been an issue with the MET exon 14 splice variants where we often don't know all the different mutations that will cause the exon 14 skipping of MET. I mean, we have a map of a lot of them, but I've had a number of patients, including some on studies, where we had a mutation we thought was exon skipping, but it hadn't been described before. Whereas if you look at the RNA, you can actually see the transcript and confirm that it is in fact exon skipping. So that's one example. There are some other fusions where RNA gives you better data as well. So I think it's important that providers know the details of the molecular profile method that they're using. Does their molecular profiling method cover all 7 alterations? Ideally, does it cover the other ones where we've got clinical studies for as well? And are there better approaches to consider? I say this because there are some laboratory-based tests of what we call LDTs that were developed a few years ago that may not include all the major alterations. So make sure your provider or whoever's doing your profiling, make sure that their profiling method covers everything that's potentially targetable.
That's a key point. Alex, we talked about, when we started this conversation, using tissue to test for molecular alterations. If you don't have sufficient tissue, you do plasma. There's now increasingly a case being made to do both. Can you comment on that?
Yeah, and I think that if we're thinking about an ideal situation that maximizes the likelihood of both detecting a driver and detecting it as quickly as possible, I hope that as we move into the future that we get coverage for simultaneous testing of both tissue and plasma. And obviously plasma has the advantage of interrogating the entire swath of genomic heterogeneity of the cancer and picking up a potential driver alteration much more quickly than tissue. But it does have its limitations in that for the most part right now with our current technologies, we're still locked into DNA, and all of the limitations of doing that were spoken about by John in the last slide where we talked about RNA apply. But I do think that doing tissue-based testing at the same time is also critical because you have a look at the architecture of the cancer and potentially for tumors that don't shed, you're able to directly sample a cancer's nucleic acid. So I think my preference would be a combined approach up front And that I think would be a patient-centric strategy if coverage is not an issue.
Yeah. Talking about patient-centric strategy, Alex, I want to share, as we wrap up this conversation, some final thoughts on practical aspects. One of the things that we have now access to is data from patients. These are real-world patient-reported data. And when patients were asked in studies conducted by the GoTo Foundation and others, how often are you being tested and do you have knowledge on what your molecular target is? There's still a lot of gaps in making sure our patients are on board. There are about 20% of the patients that do not know if their cancer were tested for molecular aberrations. And when you look at data from 2018 to 2019 to 2020, there is gradual increase in patients who are aware of testing and they are aware of the specific events that their tumor has. So this speaks to making sure our patients are on board with what is being tested for, what did we find, and understand the various pros and cons of liquid testing and tumor testing and so forth. We also need to make sure we convey to our patients about the role of targeted therapy in patients with driver mutations and situations where targeted therapy is not appropriate and immunotherapy should be used. Also, we need to talk to our patients about clinical trials. We know that with the use of shared decision-making model, we are able to achieve better results for our patients. This is something that all of us should understand and keep in mind. We also want our patients and caregivers to be aware of a number of resources that are available through the GoTo Foundation and other colleagues. You can get readily downloadable educational materials on key topics, understanding your diagnosis, understanding what is a biopsy, what is biomarker testing. So using these resources, I think, will allow our patients to be better able to navigate what is a very difficult time point about coping up with the diagnosis of lung cancer and quickly getting on board to moving towards effective therapeutic options. The lung match is a mechanism available that can help patients after they've had or before they meet with their physicians to learn more about molecular testing based on what they learn about the molecular testing, various treatment options, and so forth. This has been a very exciting conversation. I just want to wrap up talking about some key reflections. I'll start with you, Alex. Tell us what our audience should take away from this conversation from your standpoint.
Yeah, I think it's very apparent that we have many clinically actionable drivers now that match patients to highly active therapies. And so it goes back again to education surrounding molecular testing that can open up doors for treatments that really, as you've seen, beat the benefit that we see with other standard of care therapies such as chemotherapy. And I think that if we push on multiple fronts, so push on the patient front to get molecular testing done, push on education, on the provider front, that hopefully those numbers that we saw earlier will start to creep up even further.
Thank you, Alex. John, what are your key takeaways?
Yeah, I think the key takeaway is now there are just an increasing list of very effective drugs for different subsets. So if a patient wants to know what's the most important question that I should ask my provider, I would respond to that. Has my tumor been profiled for all 7 targetable alterations? Again, it should be profiled for EGFR, ALK, ROS1, RET, MET, BRAF, and NTRK fusions. And if it hasn't been profiled for all 7, it hasn't been completely profiled. In addition, now patients should also be profiled for KRAS and HER2 because we have great drugs in studies for those. That's the single bit of information that can make the most difference. Now, I think having PD-L1 levels is also important, but I think it's key for everyone to realize that if you've got one of those 7 alterations, we really have highly active and well-tolerated drugs that can make a huge difference in outcomes.
Thank you, John. Huge difference in outcomes That's a great way to finish this conversation. That's what our patients are looking for. That's what we want to provide our patients with. I've certainly enjoyed talking to you about these exciting advances. Alex, John, thank you so much for sharing your insights. I'm confident that our audience learned a lot from this conversation. Have a great day.
This CME MOC activity is jointly provided by Medical Learning Institute Incorporated, Go-To Foundation for Lung Cancer, and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/VVS860. This activity is supported by independent educational grants from AstraZeneca, Daiichi Sankyo Incorporated, Lilly, Pfizer, and Takeda Oncology. For further information concerning Lilly grant funding, visit www.lillygrantoffice.com.